All right, everybody. Thank you so much for taking the time to join us today. We're very excited to have you all here and to have such a great response to this webinar topic. So for today, we are going to be discussing eliminating pain, how osteopathic treatment can help to help you feel, move, and perform at your best. Now, just a few housekeeping items before we get started. There is a automatic chat function for most of you through Zoom. If at any point, at any time during this presentation, you have a question for myself or for Dan, please feel free to type that into the chat and I will actively monitor that chat during the duration of the webinar. If the question is specific to the topic at hand, I will ask it at the time. If it's more of a general question, we will move to a question and answer period at the end of the presentation. So for those of you who don't know us, and I do recognize most of your names on this webinar today, but for those of you who don't, Honsberger Physio Plus is all about helping you build a better you. Whether you have a new injury, you want to take your game to the next level, or you're just finding it harder to move than you used to, we are committed to helping you feel better, live better, perform better, and work better. We believe that personal empowerment is key to living a healthy life. As most of you know, we have clinics in Markham, Aurora, Burlington, and Stouffville. We also do offer home visits. And then we have a number of private practices, which is either exclusive for members of an organization, employees of an organization, or members of private health clubs. So we have 3 clinics at various Apotex manufacturing plants around the GTA. Same with Sanofi Pasteur. So we specialize in corporate wellness in the pharmaceutical sector. The Toronto Cricket Club, Ovenbird Golf Club seasonally, and we've just secured a new contract with the York Regional Police, where we will be offering on-site services for all of their members, which is pretty exciting. Again, most of you know, but our services all start with a biomechanical evaluation. We offer physiotherapy, registered massage therapy, athletic therapy, and the new service offering, which we're super excited to have Dan here with us, is osteopathy. We really focus on injury recovery, but most importantly, injury prevention. We work with motor vehicle accident individuals, people who had work-related incidents, concussion management, ergonomic assessments, sports performance, vision training, and I touched on this briefly, the corporate wellness side, which is booming in this COVID age, active aging programs, sports specific and personal training. We also have a foot guru on staff who specializes in custom orthotics, custom bracing, and compression therapy. But at the end of the day, it's all about helping build a better you. So what's the goal here? What's your better moment? The purpose of today's session is to really help you to learn how to take control of your chronic headaches, TMJ pain, and along with any abdominal discomfort or digestive issues. That's really the premise for today. So without further ado, I am so pleased to have Dan here with me today. Dan Hilborn joined our team, I guess it's been 2 months now. And quite honestly, his passion for what he does is second to none. He takes such great care of his clients and really thinks outside of the box when it comes to long-term sustainable change. So that is really what kind of excited us when we did hire Dan. And I'm really excited for the presentation he's put together today. Dan is not only an osteopathic manual practitioner, but he's also a certified athletic trainer. So we've got lots of things that we can dive into today. So without further ado, I'm going to pass it over to you, Dan.
Awesome. Thanks, Robin. So as Robin quickly mentioned, I am a certified athletic therapist as well as an osteopathic manual practitioner. And I treat everyone I work with using a very holistic approach, meaning we need to find the root causes of the problem, not just treating the symptoms. And as we go through this presentation, you'll kind of see how we look at a couple of different areas than you may have heard in the past to try to find those root causes of the problem. And you'll kind of see that as we go through the presentation. But the main concern, again, is finding those root causes to make sure that we make the pain go away and stay away permanently. So as an osteopath, it's more of a hands-on manual practice, which is going to work to improve mobility of joints, muscles, viscera, our organs, our cranial sacral system, where athletic therapy is more of a movement and exercise science approach to rehabilitation. So as we treat, we do more of the hands-on stuff to encourage you to move better, and then more of the athletic therapy, exercise, movement science background to encourage you to maintain those changes. If we keep putting you back in a position, but don't give you the tools to stay there, the pain's never going to totally go away. And that's the key to fixing a lot of these problems, is not just correcting them, but teaching you how to correct and maintain those changes by yourself. So we want to correct your dysfunction and then give you the tools to maintain those changes. So if we can switch slides, perfect. So each organ in our body is surrounded by a deep layer of fascia that connects it to the surrounding organs and our musculoskeletal anatomy. So things like our ribs, our hips, our pelvis, our abdominal muscles, our back muscles, to name a few. And our organs have a direct connection through this fascia to a number of areas that we commonly experience pain. All of our organs need to have the ability to move. So a lack of a mobility to an organ can cause a lack of mobility to that joint or muscle. An example is our kidney. It has a direct connection to a muscle called our quadratus lumborum, or our QL, which is one of the main low back muscles. So if we have a lack of mobility in the kidney, it can cause a lack of mobility to this muscle. So if we just keep treating the muscle, but not the mobility of the kidney, that muscle is just going to keep getting tighter and tighter because we're not, again, addressing that root cause. We'll talk about this in a few other examples as we continue, but again, the root is finding that underlying cause to the pain. Next slide. So some of the main causes of visceral mobility is things like posture. If we sit sort of hunched forward all day, that's going to cause compression onto a viscera. If we sit sort of hunched over or leaning to one side as if we're on the mouse, that can compress the viscera or organs on one side. Things like repetitive stress or repetitive movement. So whether that's through sport, golf, hockey, we're consistently rotating to one direction, that can cause compression in certain areas. Trauma, car accidents, slips, falls, sports-related trauma can all cause visceral types of immobility. Another major one that we're going to talk a lot about today is abdominal surgeries. Some of the more common ones are things like gallbladder, appendectomy, C-section. And it's one of the things I always find really interesting when I have patients come in who have had some of these surgeries. And I always say I find it interesting that whenever we have an orthopedic surgery, a hip surgery, a shoulder surgery, a knee surgery, we're almost always recommended to do a rehabilitation program to get that knee, hip, or shoulder better. When we do an abdominal surgery, when we're cutting through skin, fascia, abdominal musculature, we're almost never recommended to do a rehabilitation program. I've talked to a number of surgeons and I've never really gotten a straight answer as where the disconnect is between orthopedic and abdominal surgeries. I've never really gotten a straight answer, but this is absolutely something that anybody who's had an abdominal surgery should absolutely get this looked at. The last cause of visceral immobility that we're going to talk about is digestive issues. So things like IBS, acid reflux, hiatal hernias, constipation. These could be the cause of visceral immobility, or visceral immobility could be causing some of these conditions. And this is something that we'll talk a little bit more about as we continue. Next slide. Perfect. So the next thing I'm going to talk about is C-sections and low back pain. So it doesn't necessarily have to be low back pain. But like lots of women who experience experience C-sections might have hip pain, low back pain, pelvic pain. But low back is one of the more common ones. So that's what we're going to use for this example. So a lot of women will experience low back pain for a few weeks post C-section, but then that pain will slowly start to subside. This does not necessarily mean that the problem is gone. It means that the core has regained enough strength to support the back, and the body has found ways to compensate to take the load or force away from the painful area. Women should always be cleared by their doctor before beginning a post-op treatment thing post C-section. But as a general rule of thumb, somewhere around that 6-week mark is usually when we can begin this type of treatment. Again, most women on post-abdominal surgery, and this is the same for other abdominal surgeries, usually have a post-op follow-up somewhere around that 6-week mark, where we can just get cleared by the doctor that, yep, we're good to begin treatment, and then we should begin it shortly after that point. Next slide, please. Perfect. So the problem is a lot of women won't seek out treatment for this until years later when that low back pain returns because that untreated scar tissue is now not allowing that core musculature to support us properly. When we develop scar tissue, that tissue's become weakened. For a short period of time, it's going to be able to do its job to stabilize the area, but eventually that's going to start giving out. Or the compensations that our body has originally learned to help minimize the pain are starting to cause other biomechanical breakdowns. So that could be things like back pain, hip pain, rib pain, knee pain. And at the end of the day, if we just keep treating your knee, but don't fix that core musculature and give you the ability to stabilize the pelvis, get rid of that scar tissue, that knee, hip, shoulder, whatever the pain may be, again, is just going to keep coming back. It all comes back to needing to treat that root cause, which is the scar tissue, that weak core musculature, and the visceral immobility. It's not a knee issue. The knee is the side effect of what's happened. The good news is it's not too late. So even if it's been 25 years or more since you've had that C-section or other abdominal surgery, we can still work to correct it. And that treatment consists of manual therapy to limit scar tissue formation around the incision, ensure we have proper pelvic alignment, restore proper mobility to the surrounding joints, strengthen the core and pelvic stability muscles to hold everything in place, correct those compensations, and then again, reteach the body how to move correctly. It's one thing if we just loosen all these muscles and improve the mobility of the joints, but with all these compensations, your body has learned new movement patterns or incorrect movement patterns. And if we don't teach your body how to then go back to the way you moved pre-surgery, you're going to just keep, your body has learned to compensate and it's just going to keep compensating. So it's all about getting you moving better, releasing all that scar tissue, fascia, improving the visceral mobility, and then teaching you to stay there. And again, these principles are the same for other abdominal surgeries, gallbladder, appendectomy, whatever it is when you were going to have the pain originally, that pain's going to go away after a few weeks or months, but that doesn't mean the problem's gone. Our body's compensating, we still have scar tissue. Sorry.
That's okay. I just have another question from someone on the chat here.
Sure.
Now, would a hysterectomy qualify for this type of thought process as well, or will that be touched on later in the presentation?
No, absolutely it will. I don't touch on that specifically in this presentation, but absolutely. Any type of surgery, whether we're removing something, adjusting something, anytime we're creating some sort of surgical incision, there's going to be scar tissue created. And that scar tissue over time is going to cause breakdown and it's going to cause compensation. So whether that's from an ankle, like really minor ankle surgery, or a hysterectomy, a C-section, whatever it is, any type of surgical process, there's going to be scar tissue. And that needs to be addressed. And again, work on all those compensatory mechanisms, strengthen and improve mobility, range of motion, and strength. Does that answer the question, I hope? If not, feel free to ask more questions at the end.
I think that's a great start. And if there's more, I will definitely make them heard. Thank you, Dan.
Perfect, thanks. So, next slide, please. Perfect. So the next thing I'm going to talk about is digestive issues. And this kind of goes along with the visceral mobility. But for the main digestive issues I usually see are things like hiatal hernia, acid reflux, IBS, constipation. Those aren't the only ones I see, but they're some of the more common things that are out there and things that I see a lot of. Treating most of these digestive issues requires a multifaceted approach, meaning we need to look at things like diet, exercise, sleep, stress, and visceral mobility. Again, coming back to the kind of main point of this presentation is we need to look at all of these underlying issues, not just address it from one area. With the digestive tract, so as the food we eat passes through our digestive tract, it has to make its way through a number of small valves, as well as pass by several sharp 90-degree turns in our small and large intestine. I'm hoping you can see my cursor moving on the screen here. But as we eat food, it goes through our mouth, down our esophagus, dumps into our stomach here. It goes through a little valve, which when this gets restricted, it can be very common causes for things like acid reflux, hiatal hernia, very common conditions. Food then goes through our stomach and then passes into part of our small intestine. This is all small intestine here. This isn't exactly made to size or totally accurate, but it dumps into our small intestine just on the left side, right side of center here. It passes through, zigzags through our small intestine to the second part of our small intestine, which is called the duodenum or duodenum, where our gallbladder releases bile. into the small intestine, which helps with the breakdown of fatty foods. Again, another valve that if it's not working properly, we can have a limited ability to digest fats, which again can lead to a number of digestive issues, including constipation, IBS. It then zigzags through the rest of our small intestine and dumps into the first part of our large intestine, which is the large pink part going around the outside, through a little valve called the sigmoid the ileocecal valve, sorry, which isn't depicted on here, and then runs its way up, makes one of these sharp 90-degree turns, another 90-degree turn, and then out through the sigmoid colon and out through the end of our digestive tract. If these valves aren't opening and closing the way that they're supposed to, or if we develop rigidity or tightness similar to a muscle in our small or large intestines, the food we eat won't pass through our digestive tract properly, which can then lead to a number of digestive conditions. Then these digestive issues can also lead to musculoskeletal injury or dysfunction. Like we talked about before, we know that our organs connect into different areas of different joints, different muscles. So if food isn't passing through and causing rigidity in these areas, this could then be causing some of our musculoskeletal problems at the same time. We also, like we mentioned before, need to address these valves. They need to open and close correctly to release digestive enzymes and bile, like we mentioned before, to ensure that things are being broken down properly through our digestive tract. And again, if these things aren't happening, one, they're going to lead to or can lead to digestive issues. Two, they can lead to a lot of these musculoskeletal pain and dysfunction, depending on what organ or what part of our small or large intestine is getting restricted. Next slide, please. Yeah. So as we previously discussed, we must take a multifaceted approach to treat this, meaning things like we need to address diet, sleep, stress, and exercise. Through our assessment and through our treatment, we'll discuss a lot of these techniques, things like sleep, stress, exercise, what techniques you're using, what things we can implement in. And it also may involve a referral. With diet, a lot of the time I refer out to a dietitian or a naturopath, or somebody that can look at, hey, are there foods that we're eating in our diet that are causing inflammation, things that we're reacting to specifically. And by cutting some of those things out, that can help with our digestive issues as well too. So sometimes we treat that in-house and things that we'll talk about through our assessment and treatment, but sometimes a referral is necessary. But then again, we also must ensure proper mobility of our large and small intestine and proper mobility of all those valves and digestive organs. Through manual treatment, we can assist these to move and open correctly, reduce the rigidity in the small and large intestines, and then ensure proper mobility of those digestive organs. If we get all these things moving properly, we address sleep, stress, diet, exercise, it'll reduce the digestive issues and help maintain a good, healthy digestive system, which then in turn can also help eliminate or decrease some of those musculoskeletal problems at the same time. Next slide, please. Perfect. Next, we're going to talk about headaches. So there are many causes of headaches, including things like stress, lack of sleep, side effect to medications, vision issues, posture, tight and restricted muscles in our neck, as well as a lack or loss of cranial bone mobility. Next slide. Yeah. So most people think of our skull as just one solid bone, when in fact it's made up of a number of bones that all need to move individually. If you look at the diagram in the right part of the screen here, each of these different colors represents a different bone. All of them need to move individually. When our cranial bones and cervical vertebrae are moving properly, we have proper circulation throughout the head, face, brain, facial muscles, and jaw. We have proper production of spinal fluid, which is the fluid that protects our brain and spinal cord, and proper mobility of our cranial nerves. The cranial nerves control things like vision, hearing, taste, sensation in our face, movement of our tongue, movement of our facial muscles. So sometimes you'll hear people who have really bad headaches or post-concussion, where you have things like blurred vision, ringing in the ears, possible numbness or sensation change in your face. And that can be a compression or a restriction to one of these cranial nerves. Just like we can pinch or have restriction to a nerve in our neck, to a nerve in our back, we can restrict these cranial nerves, and that's going to lead to some of these symptoms that we associate with headaches, especially if the headaches get really bad. Next slide. So if any of those cranial bones aren't moving properly, circulation to the brain, face, jaw, facial muscles, and head will be affected. The production and movement of cerebral spinal fluid can be affected, and the mobility of those cranial nerves can be restricted. Any of which, if any of those are happening, often that's going to result in headaches, and often we'll have more than one of those happening all at the same time. So again, reasons for cranial bone mobility, and one of the things that we always, I always, and all the therapists at Honsberger here, always relate things back to is posture. When we're in bad postures, that's going to lead to lack of cranial bone mobility, as well as a number of other issues. Things like car accidents, slips, falls, and these don't need to be real serious car accidents, slips, or falls. Even minor ones can cause cranial bone immobility, even things like forceps used during the birthing process. So we can develop some of these cranial lesions or lack of cranial bone mobility right from the time that we're born. Surgery, and more often dental surgery, is a major cause for cranial bone immobility. Most people have had wisdom tooth removals, tooth extractions, which are pretty traumatic. We're essentially ripping bone out of another bone. And that causes lots of jarring to our jawbone, that causes lots of jarring to the temporal bone and other cranial bones in that area, which again can lead to lack of mobility. And again, those dental surgeries often can lead to headaches, and not always immediately after. If we look for treatment for this cranial bone immobility, it's important to feel for the mobility of the bones, assess which ones aren't moving properly, and encourage them through some manual treatment to start moving the way that they're supposed to. We need to assess spinal posture and improve that range of motion through joint mobilization, soft tissue work, as well as some exercises to help you maintain those postural and range of motion improvements. We need to discuss sleep, stress, and give you tools to help cope with some of that, as well as macular health. The macula is part of our eye, which is very important for vision. And through supplementation or dietary change, we can actually help to prevent further degradation of that macula. When we start to have vision issues, it causes us to squint a lot. And a lot of people are going to have headaches involved with staring at computers, staring at our cell phones. And when we start to squint, that brings us into bad posture, and it also causes strain onto the eyes, which can be a major cause of headaches. So we actually have some great new technology here that looks to assess your macular health. And if we're having issues with that, again, that's something that we can address possibly through supplementation, possibly through diet, but it's something we need to address and at least assess to make sure we're looking at all of these things that can be leading to your headaches, and make sure that we're treating all of these things that can be contributing to it. Next forward. So going along with cranial bone mobility is jaw pain. And most people have heard of the term TMJ and know that that means our jaw joint. If we break that acronym down, it means temporomandibular joint. Mandible or mandibular, meaning our jaw bone, which as you can see in the diagram here, the jawbone. Temporal or temple, meaning our temporal bone. So half of this joint is made up of one of our cranial bones. But when a lot of practitioners treat the jaw, we don't look at cranial bone mobility. We just treat the mandible or the jawbone itself, as well as that surrounding musculature. If we're only treating the jaw and the surrounding musculature, we're only treating half the joint, and usually that means we're only treating half of the problem. We need to treat the whole problem to fix those underlying issues. Next slide. Yeah. Again, looking at causes of TMJ dysfunction, and another common theme that we've seen a lot of in this presentation is posture. We need to correct posture to ensure proper jaw joint mobility. Things like uneven chewing. If we always chew on one side of our mouth, that's going to cause degeneration more on one side than the other. Trauma, whiplash, motor vehicle accidents, dental surgeries, breathing mechanics, and then again, cranial bone mobility all need to be looked at, in things that can cause TMJ or jaw dysfunction. Jaw dysfunction is also a major cause of headaches. So whenever people come in for headaches, we always need to assess that jaw mobility to ensure that it's moving properly, to help make sure we treat all those underlying causes of headaches. Next slide. So when we're assessing the jaw, we always need to look at the neck, upper back, shoulders, jaw, and cranial bone mobility. We have a number of muscles that run from our cranial bones to our jaw, our neck to our jaw, our upper back to our neck, our upper back to our jaw. So all of these areas are connected. And if one is out of alignment, they're all going to be out of alignment. If we just work to treat one, again, we're not going to fix all of these underlying issues. We need to correct posture. Things like forward head posture, shoulders starting to roll forward, are going to put tightness on those anterior or muscles in the front of our neck that are going to pull on the jaw. If we have a neck or our cervical spine that's slightly bent to one side, it's going to cause compression on one side of our jaw. So we need to correct all of these things to, again, treat all the underlying issues of the neck. When looking at the jaw specifically, we need to assess uneven movement. Is it translating left or right as we open and close it? Are we getting clicking, cracking, popping sensations? These are all indications of jaw dysfunction and things that we need to look at and assess. Next slide, please. Similar to before, when we're treating that jaw, we need to loosen all those muscles that are affecting uneven jaw mobility. We need to correct posture in the neck, upper back, shoulders, mobilize that jaw joint specifically, look at, assess, and improve that cranial bone mobility. And then again, most importantly, is give you the tools to maintain those changes, which could be some stretches, exercises to correct posture, and improve joint range of motion. The other thing we look at a lot with jaw dysfunction is breathing mechanics that we talked about before, which could also involve a referral to our in-house dentist or dental expert, who's not actually a typical dentist, but he specializes in breathing, TMJ alignment and dysfunctions, as well as sleep. So if you're grinding your teeth, if you have jaw joint degeneration, breathing dysfunctions, if you're a mouth breather, these things all need to be adjusted, or those jaw or TMJ pains will never totally be corrected. He works to create dental orthotics that helps to correct these issues. And again, we need to treat all the underlying issues. And if one of these things are affected, having him in-house to be able to assess, look, and then treat some of these issues is going to help work to get fix all those underlying conditions. Next slide, please. So in conclusion, when we're assessing musculoskeletal injuries, it's important that we also always assess visceral mobility, cranial bone mobility, and jaw mobility to ensure we are correcting all of these underlying issues of your pain and dysfunction. We now know that our organs connect into the muscles and joints and can affect their mobility. We know that the muscles of our jaw connect into our shoulders, our neck, our upper back. So a jaw dysfunction can be causing pain in any of these areas. Even if we don't necessarily have jaw pain, a translation or a lack of mobility in that joint can be causing pain and dysfunction in any of those other areas. A lack of cranial bone mobility can affect the mobility of our spine, leading to pain and dysfunction. If you do suffer from headaches, migraines, an assessment of that cranial bone mobility does need to be done and should be done to ensure we're treating all those areas causing the headache. Ensuring there's proper cranial circulation, proper fluid production, and movement, and there's no cranial nerve restrictions. If you do suffer from digestive issues, IBS, acid reflux, constipation, hiatal hernias, that visceral mobility should be assessed and treated to ensure the foods that we're eating are being digested properly, and we have correct movement and mobility through that digestive tract. If you have TMJ pain or discomfort, again, that cranial bone mobility needs to be assessed, as we know that temporal bone makes up half of that joint. Lastly, when in doubt, get it checked out. We need to treat the cause of the problem, not just work on the symptoms, which again is going to involve some manual therapy to correct those imbalances, strengthen to maintain the changes, and then give you the tools to make those changes permanent. If we start addressing all of these things, these are the keys to making sure that we really treat all of these issues and ensure that these changes become permanent. Like I said, and you can see on the slide there, if you have any questions or need advice, feel free to contact me, or you can come in to book an assessment. If there's any questions, I feel happy to answer anything that you may have.
Thanks so much, Dan. I think that was great. I think you've probably answered a lot of people's questions in such detail. For those of you who aren't aware, Dan treats in both Markham and Aurora. He's in Markham on Mondays, Wednesdays, and Fridays, and he's in Aurora on Tuesdays and Thursdays. Again, if you are interested in following up and asking him some questions, you can do so by email, or you can see him in person. If there's no further questions, I don't think there is at this time. We wish you a great day. We appreciate your time, and this webinar is being recorded, so we will send a follow-up email to everybody with the link to the presentation. Thanks so much, everybody, and have a great day.
Thanks, everybody.